I think we've talked about current cases and how that's being applied to today, but I guess future directions and where we might be headed in the future. Sometimes our patient also includes the mothers of our patients as well, too. Flavia, can you give us an update on what you're studying now?
We are really, we are looking always to the future, and of course, all of us are pediatricians, but as a pediatrician, we have to take care of the health of the baby since he is in the womb, he is in the pregnancy. So, and we are also, the new frontier, the new scenario that can be a new deal, let's say, in the use of probiotics or in the use of health, is the health or the dysbiosis of the oral cavity. As everybody knows, in the oral cavity, there are more than 900 species, and this creates, again, the oral microbiome. And why is so important? Because in the oral cavity and, let's say, the mucosa and the tooth are affected by a very, very common and spread disease, that is the periodontitis. That is differentiating gingivitis and in periodontitis. Gingivitis when the inflammation and infection is located in the gingiva, and periodontitis when there is a chronic switch in a chronic infection and involves also the structure around the tooth.
This seems like a very local effect, but there's systemic effects.
Exactly,
also, right?
It seems a local effect, but we have two problems with this. That one, it's that it's very, very common, almost 70% of the population below 40 years of age, from 20 to 40 years of age, is the peak of this disease. But the main problem is that the periodontitis has been related to a lot of systemic disease. As you can see here, so many, IBD, kidney failure, all the disease related to autoimmune disorder, Alzheimer's, respiratory disease. But what we are really care, it's this, is the correlation with preterm delivery. And so this could be strange, and think how this can be possible. How bacteria from, or dysbiosis from the oral cavity can reach the womb, can reach placenta and amniotic fluid. Of course, we have two different theories. If we just agree, Jens is laughing because he's one of the authors of this paper.
Congratulations, Jens.
And then we can discuss later on. We discussed already bubbles 2 days ago. Okay, but this is not important. One of the authors is here. And there are two theories. One was, the old theory that is the sterile womb paradigm. So we study on the book that amniotic fluid is sterile, meconium is sterile, placenta is sterile. But the new approach, or the new, let's say, theory, it's in utero-colonization paradigm. So means that, has been shown, a lot of studies show that amniotic fluid is not sterile, placenta carry its own microbiome. And so the baby that goes during the, let's say, 7 months of pregnancy, because until it starts the swallowing process starts 14 weeks of gestation. So after 14 weeks of gestation, the fetus starts to swallow. What does it swallow? Amniotic fluid. Amniotic fluid takes the microbiome from the placenta. So the baby intestine colonization came from the amniotic fluid and the placenta. And the microbiome or the colonization of the placenta itself can come from the oral cavity, from the intestine, or from the vagina of the mother. So that's why it's so extremely important that the mother health is taken into account and is taken under the light. We have to take care absolutely in a very special way to the health of the mother if we want normal and eubiosis or colonization. But this is not the only reason, because of course, if the mother has got some infection of dysbiosis in the oral, like this, because look, this is the mouth of a woman with periodontitis. So what's happened? Happened that there is an indirect pathway to reach placenta, because even though in the oral mucosa there is not the submucosa, but in the lamina propria there are a lot of lymphocytes, a lot of mesenteric lymphocytes that can take all the inflammation pathways and carry to the general immune system. and that can create an inflammation again in the placenta. So this became an holobiont. So not a two system, but three system, three complex microbial system that interact one each other. Oral placenta, vaginal placenta, gut placenta. But how this is important? It's important because whenever a maternal microbiome is in eubiosis, then there is a normal metabolome and a normal inflammasome, and there, this kind of inflammation balanced goes to term delivery. But when there is a dysbiosis, then there is all the altered inflammasome, all the altered T cell subset, and then the preterm delivery can happen. And this is the main slide important because who is giving the trigger to the delivery is not the mother, is not the placenta, is the intestine of the fetus. It's the intestine of the fetus that trigger the starting of the contraction for delivery. So whenever the baby is swallowing, inflamed, let's say, or dysbiotic microbiome, and all the set of the inflammation is altered, the intestine of the fetus is inflamed, and then that is the setup for the preterm. So it's not the mother that starts the contraction, but is the fetus, and especially the intestine of the fetus.
It's a very provocative theory, and spreads a little bit more in terms of the reach of pediatrics and pediatric implications. How would you test this clinically, or what work has been done in this area?
There are a lot of studies there are a lot of studies that have been done during the 2000-2002 trying to correlate gingivitis and periodontitis severity with preterm delivery. But the meta-analysis failed to show just because there were not homogeneous the study. It was impossible. Hania, that is the major expert in meta-analysis and just to, compare the study, can just tell us that when the studies are not homogeneous, when they don't follow the same methodology, it's so difficult to analyze and to put it in a meta-analysis. So far, there are not final words saying that preterm delivery is related scientifically to gingivitis or periodontitis, but there is an increased risk. If the percentage of periodontitis in the normal population can reach 70, in the pregnant woman can reach 100%. So maybe one thing that we can do is taking care of this periodontitis in the pregnant woman and cure. And there are this nice study that have been published a couple of months ago where the Lactobacillus reuteri combined with another, two strains of Lactobacillus reuteri combined reduce the pregnancy gingivitis. It's a randomized clinical trial, and this has been shown to reduce also some cytokine or pro-inflammatory cytokine. So maybe this can be an approach to cure the periodontitis and the gingivitis during the pregnancy, but even before the pregnancy. I can say again, I have, my idea, my obsession could be is prevention. So that's it. Maybe we can conclude that the oral microbiota plays an important role during pregnancy. That, of course, it's a challenge. It's a new possibility. Why don't try to follow this street? And maybe supplementation with the oral probiotic can create iobiosis in the oral and can have a beneficial effect on pregnancy and in health of the newborn, of course, because preterm delivery, it's an emergency. It's a worldwide emergency. And of course, when the woman is pregnant, and a multidisciplinary approach could open a new scenario. And the role of pediatrician is, again, to take care of the infant health within the pregnancy.
Great. Well, thanks for giving us a window into the future in terms of what else is going on.